Hello, everyone. Welcome to the 45th episode of Let's Talk Inclusion. My name is Manobina Chakraborty, the host of this talk show. And today we will discuss a very important aspect of inclusion. It's about the relationship between ADHD and aggression, and of course, some strategies to manage them. I'm glad to introduce you to my guests of today's episode. They are Dr. Siddharth Shah, renowned pediatric neurologist and epileptologist, joining us from Ahmedabad, India, and Dr. Marta Hawkins, senior educational leader and employability consultant, joining us from London, UK. Good afternoon, Dr. Hawkins.
Hello, everyone.
And good evening, Dr. Shah. Welcome to Let's Talk Inclusion.
Hello, thank you so much. Thank you for the invite.
Thank you. So before we formally begin our discussion, could you please tell our viewers a little more about your life and work, Siddharth?
Okay, my life isn't very interesting. So I'm a doctor. I'm a child neurologist. I started off my training with an MD in pediatrics from Ahmedabad itself, and then I decided to go to the UK for further training. So that was back in 2001. I've been around places in the UK, but most of my child neurology training was at Bristol Royal Infirmary, Bristol Children's Hospital in the southwest of England. And then in 2011, I decided to come back to India. Initially, I had my own solo clinic or practice, but now we are a team of people who provide child neurology services in Ahmedabad, and we've joined to start an institute here called RICN. A couple of other doctors have joined. They've also been trained from the UK and other parts of India, from Mumbai. So we have a mix of outpatient duties every day and some indoor patients. The outpatient duties, we have a mix of patients come to us, predominantly epilepsy, neurobehavioral disorders, neurodevelopmental disorders, and neurogenetic disorders being the mainstay. So that's about it, really. And I think we try and help as much as possible. Neurology being one of those complicated fields, especially child neurology, we all would agree. It's not always straightforward. There aren't treatments sometimes available, but we try and help where we can.
Yes.
Very true. Thank you very much, Siddharth. And now, Marta, could you please tell us about your life and work?
Hello, everyone. I am Marta Hawkins. I am a researcher, academic researcher in diversity, belonging, and identities, diverse identities, very broadly understood. And I'm also a lecturer and a coach based in London, where I've set up a foundation called University for Children, mainly to support parents and children throughout the pandemic. And now we offer the support to students and their parents and teachers who have special educational needs and disabilities. And I also offer consultancy to schools and universities, promoting neurodiversity and experiential teaching and learning methods, which need to be adjusted to neurodivergent profiles. Also, quite importantly for my own personal journey, I received a diagnosis in ADHD quite late in life, and that has changed my life completely, I must admit. It changed my understanding of who I am, and it changed the way I see my ways of communicating with others and also my abilities. Since then, I have become a champion of neurodiversity, and I've been educating parents, employers across different sectors, showing them the complexity of neurodivergent comorbidities, and also, I would say, the beauty of our abilities.
So nice. Thank you very much, Marta. Thank you for coming here today. And Siddharth, since Marta and I are basically from the field of education and you are from the medical field, so it would be best if you could tell us what the neurological basis of ADHD is. Could you?
Yes. So, um, having come back to India for a number of years now, uh, what I've understood and I feel is that either there is a real explosion and an increase in incidence of ADHD, uh, or we have become better in recognizing and diagnosing ADHD in children. I think it's a bit of both. Now, that much we understand. What we don't really very well understand is why does ADHD happen, and what is the actual neurological reason behind having ADHD? Why is it much more common in boys? Why do we see it? Why do we see the hyperactivity subtype? Why do we see the attention subtype? And why do we see mixed subtypes sometimes? So there are more questions than answers. But over the years, as a clinician, uh, these are, I mean, we're talking about primary ADHD, isn't it? So, yes, the secondary ADHD, there's a list of reasons of why ADHD happens. But if we talk about primary ADHD or genotypic ADHD, as some people like to call it, um, these are children who were born perfectly normally. On examination, they seem to have no neurological deficits. And on a normal MRI, they seem to have perfectly normal structural brains. So it can be quite perturbing and difficult. And sometimes it's difficult to explain to parents, why does their child have ADHD? But if we dig a little bit deeper, there have been studies now, and we do have a little bit of understanding about the more about the brain structure in ADHD. So, number one, when you look at a normal MRI, there are areas of the cortex and some areas of the subcortex. So that's your gray matter.
Your video is frozen, Siddharth. There must be a technical problem, maybe a connectivity issue. Siddharth, can you hear me?
Hmm.
Marta?
Well, I hope that he will be back in a minute.
I'm sure. I'm sure.
Oh, he is back.
Yeah,
And
he's back.
yeah,
Siddharth, your video was frozen actually. So if you could just start it all over again.
yes. So So I was just talking about the MRI brain there, and if we now look at from studies point of view, and we look at those MRI brains carefully, there are areas of the brain where the cortexes look less developed, or they look slightly lesser in volume. So that and that is compared to kids who don't seem to have symptoms or do not have a diagnosis of ADHD. And that does seem to be a slight basis for the reason of having childhood ADHD. The other area that gives us a little bit more understanding is fMRI. So when you talk about functional MRIs and you look at circuits and how activation of the brain happens, there does seem to be, especially connections with the frontal cortex. There does seem to be some basis that the frontal basal ganglia cerebellum, so that's going from front to the middle to the back, that kind of circuit does seem to be affected in children with ADHD. So maybe in primary ADHD, there is some predisposition to develop that, but it just doesn't start and end there. There are a lot more reasons, and there are environmental factors. People talk about neurotransmitters and neurochemicals as well, and so it's a complex model. But we've just about started to understand why does ADHD happen.
Okay. Thanks for enlightening us. Siddharth. And is aggression related to ADHD? What do you think, Siddharth?
Yeah. So in our clinical practice, we see a long list of comorbidities associated with ADHD. And again, we're talking primary ADHD and secondary ADHD. And so primary ADHD, you talking about children having learning difficulties, children having ODD or aggression,
Yeah,
children having difficulties in socializing. And if we take the liberty and expand it a little bit more, then of course a large proportion of patients with ADHD or hyperactivity could have autistic disorders as well
yeah,
associated.
true,
Uh,
true.
in children with ADHD, we see a higher incidence of epilepsy. We see a higher incidence of migraine. So yes, so there does seem to be a connection, and there does seem to be a long list of comorbidities we need to screen for. And it can be the other way around as well. So you see patients with epilepsy, and then when you screen them, they can have attention disorder along with it as well. So it can be both ways that way. So ADHD having a higher incidence of epilepsy, and patients with epilepsy having a higher incidence of ADHD. But
Okay.
yes, coming back to your original question, yes, aggression does come into the list of comorbidities with ADHD.
Thank you very much. And Marta, what is your experience about this ADHD and aggression?
Well, we definitely have observed the dominance of aggression among ADHD children at school on the pre-adolescence level. From what the Department for Education in the UK has reported is 50% of all ADHD pre-adolescents at schools show clinically significant aggression. And that is worrying because it is related to schools exclusion, which is a big problem in the UK. From that group of ADHD children with aggression as an additional comorbidity, 2/3 of them become likely to be permanently excluded from school when they are between 4 to 16 years old. So this is a very high risk which affects education, but also affects families, school environment. And when we think about the impact of being excluded from school due to aggressive behaviors on later life, it appears that there is a additional connection, like increased psychosocial burden and other deficits, functional deficits in ADHD people when they become adults, becoming prone to delinquency, criminality, anti-social behaviors. So we are speaking here not only about educational challenges, which we face as teachers, parents, but also we are speaking about a social risk, economic risk, if they are not treated and they are not working, because, for example, it happens a lot, they are in jail. That can happen if they are not supported and looked after on that early level of school. There are methods, and we are, as teachers, encouraged now also by the government to prevent children from being excluded as much as possible and offer them extra support. There are also new policies in the UK to make sure that every school has a specialist in neurodiversity that we call CENT-CO, so the coordinator for special educational needs. This neurodivergent challenge is taken more seriously. and ADHD children quite often are in the center of it. But as Dr. Shah said, it never is just ADHD. There is always some other comorbidity with this syndrome, quite often autism, dyslexia, dyscalculia, OCD, which are very difficult to be supported holistically. But there is more and more pressure on schools to educate teachers to be aware how to support those neurodivergent children while they are also teaching neurotypical children and while they are specializing in their own subject. So you can already see that we have this bigger challenge in the educational system of how to be a teacher, how to support children with neurodivergent abilities and challenges, how to communicate with parents who are worried. But I'm glad that there is this pressure, and I'm glad that this awareness is bigger and bigger, because even 5 years ago, we didn't have so much support as we have now. And I think that how much we all suffered, but the pandemic had triggered loads of funding and support to schools.
Yeah, very true. And you're talking about criminality, related criminality in life. I was also reading a paper the other day which represents a study that investigates between childhood ADHD and later criminality. I share the link here for our viewers. Just a minute, please. Here is the link in case our viewers would like to have a go. And the other day when I was talking to you, Marta, you told me about a similar study in the UK, right? Would you like to elaborate on it a little more?
Well, the Department for Education in the UK has produced detailed reports using local data from the local governments, but also national data across all 4 nations in the UK. And it is quite evident that geographical location matters. So in a small country like the UK, and imagine, India, that must be even more vast. Really, how children are supported depends on where they live and where they come from, which, can be quite worrying when we think about disadvantaged communities and schools which don't receive enough financial support. Also, there are certain pockets of poverty which is rising globally, not only in the UK, where children are more affected because families in those areas are not that much prepared to offer support to their own children. There is not enough awareness, and I think what is also missing is the knowledge among parents of what rights they have. And that's what the reports from the Department for Education emphasize. Parents, you need to educate yourself what rights you have to receive support free of charge, so your child can be supported at school and outside of school, and also support for the families, how to change their own thinking about their own child, especially if for quite a long time, I'm sure that Siddharth would tell us more about it, how parents find it difficult. It is very difficult for them to actually accept that their children may suffer from ADHD and other comorbidities, and they quite often prolong that period of triggering the machinery of support because they either feel that it will pass, the child will outgrow it, or the school should do something, and if the school is not doing anything, it means that things are all right. But actually there is a lot to do in the family, and the family could could demand support from the school and from the local authority if they knew that they have those rights. So we have a lot of, I would say now, encouraging messages from the Department for Education, the Department for Health and Social Care in the UK, to show the way to parents and guardians how to collaborate with schools, how to work with teachers, so the children can be supported individually, because not two children with ADHD are the same, which makes things even more difficult.
We have policies in place in India, but there's a huge gap between policies and implementation, right, Siddharth? What is your opinion about it? She was talking about the rights of parents and the education, what the parents should know. We do have some policies in place, but there is a huge gap. Inclusion is in the books and the newspapers and the papers, but true inclusion, are hardly taking place in India, as I know. I may be wrong. Siddharth, your opinion?
Yeah, so I was going to ask you the same because, I don't know what happens in your part of India, but, we find it extremely difficult at the moment. Number
Siddharth,
one,
I'm in Ahmedabad. I'm basically from Calcutta, but now I'm in Ahmedabad.
okay, great. Yeah, yeah. We hadn't spoken before. Yeah. So,
Yeah.
one, kids haven't been to school during the COVID years. So, that's been a huge problem. Even normal kids are finding it difficult to integrate back into offline schooling or physical schooling after online number of years of online schooling. But yes, so me as a doctor or we as a team, uh, yes, we make a diagnosis. We tell the parents where the problem is. We can write letters for the school or and give them, some kind of guidelines of how best their child would fit into school. But as you said, schools are not ready to accept. They're not ready to go that extra mile to look after, that one child in the classroom out of the 40 students we have or 30 students we have typically. Uh, and parents find it a daily struggle. It's not unusual that kids are parents are being told to go take their child to a special school
Yeah.
or try and change them to a different school. Uh, but there aren't special schools which even cater to this problem really.
Yeah.
So
And actually, it is difficult also because one is to 40. The other day, I was reading a paper where it is mentioned that 1 is to 79 is India's teacher-student ratio for special children. So,
yeah,
what should we say? When I was working in the UK, I used to work in the autism unit of a mainstream school. There we have teacher-student ratio 1:6, with 2 teaching assistants. That means 3 adults is to 6 children. But it is really very difficult here in India, and that is why, yeah, but there are a handful of people working here and there. It is I think a bit easy for children who have some differences physically, some physical differences, to accommodate them in classrooms. Is if the infrastructure is in place, it is, I think, all right. But those who have neurological differences, it is really difficult in this part of the world, because we need trained teachers, we need proper infrastructure. And yeah, but there are people who are working on this. So hopefully, let's hope for the best. That's what I can say. Now let's come back to the topic. Siddharth, I would like to ask you something. Does ADHD medication help with aggression?
yeah. So yes, so the first thing is, yes, we do have medicines for ADHD, and we do prescribe medicines for ADHD. But we would, of course, let our viewers know that that is not the first thing that comes to mind when we talk about ADHD treatment, and it's not the only thing that comes to mind. So then there's a process. So number one, a diagnosis of ADHD should be made by a specialist or a person who has an interest in treating these disorders. So it could be a pediatrician, it could be a neurologist. Like in the UK, we have community pediatricians, and then we have neuro disability consultants in tertiary centers, and they are often the ones where the referrals go up to. There's a process of making the diagnosis, which includes taking a detailed history. It should be a history from the family perspective, the environment that the child lives in, include details such as birth details, because as you would know, prematurity and extreme prematurity itself would be a high risk factor for developing ADHD. Uh, of course, you would ask about the family history of ADHD, any siblings who have gone through similar problems or diagnosis, uh, a clinical examination to make sure there are no underlying secondary causes for that ADHD, in which case you need more detailed investigations. But otherwise, if you've done a history and clinical examination, then you could come to a clinical diagnosis without using any tests. There are scales. There are a number of scales we can look into for severity of ADHD, because that would help you in making a decision on treatment. Of course, the diagnosis should not be made just on those, but it's a combined clinical history examination and using of those scales. Once you've done that, you want to start with a process where you're planning the treatment and strategies with the parents and with the child. You want to make sure that you uh, at least tried environment modification. Removed any negative factors that are leading to ADHD in that particular child, and try and provide support at school. Once you've done that step one, yes, there is a step two, which is often medication. And studies have shown that a combined approach often works best. Uh, there are three medications that are used commonly around the world. The first one being methylphenidate. It's a licensed drug, needs a prescription everywhere in the world, and is available in India in short-acting form and long-acting form. Often tends to be my first line of treatment, because I trained in the UK, and the UK and the Europe generally uses methylphenidate as first line. Once you've tried methylphenidate, and if you want to switch to something else, then lisdexamfetamine is often available in UK, US. I'm not 100% sure whether it's available in the UK or not, but definitely in the US. It's not available in India. And the other ones that are available is atomoxetine. Atomoxetine can be tried as an alternative to methylphenidate. It is available in India and other parts of the world as well. Uh, Sometimes can be tolerated slightly better than methylphenidate. And lastly, there's another one which is guanfacine. Guanfacine. Guanfacine is not available in India again. It is available in US. I've seen some of my patients from the US who have been on guanfacine. Of course, before stopping about medicines, a word of caution: they all have side effects. They need to be titrated carefully. Uh, uh,
Question.
yes. Yes. So we just had a question pop in, say, what can be the long-term side effects of the medication? So all the medicines have different profile of side effect. There are short-term side effects and long-term side effects. But I'll talk about methylphenidate because it's one of the most widely used medication. So methylphenidate, you want to be sure at the start about that the child does not have hypertension or a family history of hypertension. The child does not have a family history of cardiac disorders and has had a proper evaluation by yourself done. And that is because it has the potential in longer run to create hypertension or give a side effect. In the short run, slight discomfort in the abdomen, poor appetite tends to be one of the major side effects. And sometimes even we find at smaller doses that a lot of children find the sedation unacceptable because, of course, it's a short-term drug, the plain methylphenidate, and the peak effect is 4 to 6 hours. So you're giving it before they go to school with the hope that they can concentrate better, they can perform better in school. But if it's going to cause sedation in the child, then there's no point in giving the medicine because they're going to be probably sleeping in school and not being able to perform as they would. Uh, and similarly, all the medicines have side effects. So at a regular period interval, you need to get your child checked by the doctor, and you as a parent and the child and the doctor needs to decide that the medicine is giving you the benefits that you are looking for.
There's one more question. Can you see Siddharth and Marta?
Yeah.
That's a question for Sid, I think.
Siddharth, I think.
Can you see it, Sid?
Yeah. So Bina is asking that she gave the medicine Orleans, which is olanzapine, for 1.5 months, and then she stopped giving it to the child, and it seemed like the effects were gone and the symptoms were there again. So is it that the child is getting addicted to the medicine? Okay, so I wouldn't use the word addicted, but yes. So you have been being you have treated the symptoms by using a medication. It seemed to work. Number one, never stop the medicine abruptly. I see that quite a lot here, and we should carefully be counseling our parents and children that if ever they are coming off the medication, it has to be a slow weaning process and never stop it just abruptly. So not just stop giving it for 2 days, and that can be quite dangerous in case of a lot of medicines. So the second thing is, has the child been addicted to it? No, I think it's just that a lot of these medicines are short acting or are symptomatic treatments. So it's like taking paracetamol for fever. You've taken paracetamol and your fever's disappeared, and then the fever appears again, and you have to take it again. So it's a little bit like that in short term. Of course, longer term, we hope that along with the medicine and along with the process of therapy and a structured environment, you will be able to bring permanent changes to your child's behavior.
Mm-hmm. One more question related to medicines.
Yeah. So Shruti wants to know Accepta or Inspiral, which is better for ADHD child with aggression. I think that's a very valid question. So Inspiral being methylphenidate and Accepta being atomoxetine. So these are two options that we just mentioned. I think personally, this is personal practice. Again, I would recommend methylphenidate as a slightly better drug for children with ADHD and aggression. Though I must say that there have been trials of comparing both, and they both seem to work. The only difference is that methylphenidate tends to have a much shorter duration to kick in terms of its effect. So you could start seeing the benefits within a week of taking methylphenidate. Whereas for atomoxetine, you have to take it much longer. We usually find that at least 2 months of treatment is when you start seeing the benefits of the medication.
Okay. There are so many comments. I'm just trying to accommodate them all.
Yes, so I'm glad people are seeing the show and they're listening to it.
Yeah.
Yeah. So Vijaya Prakash wants to know, do these medicines make the child dull or sleepy? Parents tell us so. I mean, you're right. As I started off, that sedation is a side effect of the medicine. Uh, in fact, most medicines that work on the brain do tend to have a side effect of having sedation. And this is where careful titration of the dose is very, very important. The idea is not to make the child dull or sleepy. In fact, the effect should be the exact opposite. You would hope that the child is able to pay a lot more attention in class and to be able to produce a lot more positive work or results. I would say if the child is dull or sleepy, you need to cut back on the dose, and you might want to also look at the timing of when you are giving the medicine, and that might need to be altered.
Thank you, Siddharth. Now, I think this question is for you, Marta.
Well, I think it is important to go back to the triangle that Sid mentioned before in terms of handling ADHD and aggression. So medication on one hand, behavioral therapy, and also we gain more and more knowledge about the influence of a diet. So I have experience in behavioral approach. What can we do in terms of our work at home, but also trying to change what is happening at school, which is not always in the parents' hands, but that collaboration can influence some changes. But I would like to mention a couple of things that every parent of an ADHD child with impulsivity, bordering aggression can do at home. It is important to start from imagining impulsive behavior, this reactive impulsive behavior, but that's what aggression in ADHD children is. It's a reactive impulsive behavior. It's important to imagine it in a circle, which you can call a holistic circle. But yeah, I am an ADHD person, so obviously I had to draw it for myself. This is the vicious circle of escalating dysfunction. So it's a vicious circle because we have a child who is in between aggression, frustration episodes, and it is very difficult to stop it. But we can change the direction, and we can reduce certain kinds of the degree of escalation. And I would like to highlight one very important aspect of reaction of an ADHD child to a situation where a child feels somehow undermined or criticized or excluded. When a child at school or at home feels in any way rejected, that rejection can trigger an episode of frustration, anger, or what we see as aggression. Medicine, and we have Dr. Shah to support this with evidence, medicine does not yet fully understand why it's happening, but we know that certain situations at school and at home can trigger aggressive behavior. Rejection at school by peers, criticism, scolding off, telling off, punishing, shouting will trigger a reaction. And that reaction other children see as weird, unusual, other children can be affected. They can even fear and go to teachers to complain. Then other parents come and complain about the that one particular child. And that is, in this very moment, already the cycle of the vicious cycle of an escalating dysfunction. If we don't stop it, if we don't interfere, that child starts feeling like an odd one. The child can be called names. The child sometimes is called lazy or stupid. Then they start imprinting it in their own mind that they may be stupid or lazy. So they feel that they need to attack to defend themselves. Can you see? So we cannot really stop this vicious circle unless all the participants, parents and teachers and social workers understand why it's happening and what is triggering it. And let's not forget that if there are problems in the family, or the diet is completely off the hook, including a lot of sugar or fast food, or a child does not have safe sleep that could help healing, all those environmental factors, they escalate the genetic precondition for the propensity for more aggressive behavior. We need to work together. We need to, at home, introduce very simple exercises like introducing routine, repetitive schedules that would create psychological safety in the child's mind. We need to reward the child. We need to be very aware that criticism can develop something that we call rejection sensitive dysphoria, which is a very common comorbidity going together with ADHD. And once a child has this dysphoria and rejection fear, it can become imprinted for adult life. When a child becomes an employee, for example, who is constantly afraid of any kind of criticism or feedback, or even, when they go to university, they cannot study because any comment, any reflection on their behavior, they take in very augmented size, and they can fall into depression. It can make the other mental health areas much worse. So we need to be aware that a child needs to be treated very gently. We need to engage the child physically, sensorially, somatically, so the dopamine can have bigger levels, even if they are not on medication. But if they are on medication, it can actually supplement the positive influence of physical exercise is well researched. We need to remember about the diet, and we need to remember about structuring the day for every child, and making sure that the child develops a safe structure of repeated tasks and behaviors for which we reward the child rather than punish.
Yeah, very true. And Marta, you were talking about the depression and anxiety and other things. These are basically mental health issues. So I would like to ask you, Siddharth, don't you think these conditions also should be treated, and maybe a psychiatrist can help, or any other medical specialist in that?
Yes. Sorry. Could you repeat the first part of your question?
Yeah, Marta was talking about depression and anxiety as well, and it is quite very often we see these things in the children and young people with ADHD. So, don't you think these conditions should also be diagnosed and treated, and who can help us in that?
Yes. So absolutely. So I think this is where the whole treatment part can be very, very tricky. And you could have patients or children who have very straightforward kind of cases or symptoms. But of course, on the other hand, you could have patients that have comorbidities. or you have children who develop one because of the other, as Marta very beautifully described. So, so it's a constant evaluation and looking at what symptoms are present, and see what treatment is required. I think a clinical psychologist here has a big role, because and the therapist in watching the progress of the child, and of course watching what symptoms are playing a part in the kind of disability of this child. Uh, of course, if there is childhood depression or depression in an adult, involving a psychiatrist would be an excellent idea, because that would not be in the realms of a neurologist or a pediatrician or a physician to be able to identify and treat.
Okay, thank you. Thank you very much, Siddharth. There is one more question. Please suggest how to tackle aggression in ADHD or autism. What measures should we take to stop their aggressive behavior? I think it's a mother. The question is from a mother. Our society is not at all supportive. That is the key point here. So parents are really helpless in this situation.
Very good question. When I was preparing for this talk, I have come across a piece of research that actually is entitled ADHD and Aggression, that I can send in the chat the link to. And what actually research shows, and quite often different foundations and charities use the research findings to develop tools of how to deal with this on the practical level. And we know that if we collaborate, if we encourage the school to work with us, the results are much better than if the parents worked on their own, just because the child spends so much time at school. So even though parents can achieve better results at home, but without reinforcement at school and vice versa, then we don't have that flow of support across different areas. For that to achieve, we need to develop a new language. And I'm very interested in this aspect. And I've been reading a lot recently on how to speak to a child when a teacher or a parent, what language, what verbs, what adjectives we need to use when we interact with a child before the escalation, the next escalation. It is proven in research that children with ADHD have a lot of capacity for emotional experiencing of what is happening around them. But what they don't have, because they are too young, is to reflect critically on their emotions. Emotions happen. The child does not have any concept of tomorrow and the day after, or the consequences, in 5 years. So the child is engaged in this moment, now and then. What we as teachers and parents need to do, we need to equip the child with the language that would allow the child to self-reflect on what is happening with them. And there is, for example, an organization in the UK that provides free materials, like, for example, PDFs like this one, that a parent can print out. The organization is called ADHD Foundation, very easy to remember. They have loads of PDFs and booklets which a parent can download and develop with the child together a journal, reflective journal, where they will be writing about different situations, escalations that happened at school or in a shop or at aunties and uncles, when all of a sudden a child showed aggressive behavior and nobody understands why it's happening. We cannot then force the child then to reflect. No, we need to bring the child back home to the safe environment, and slowly, bit by bit, develop the vocabulary of the child. A smaller child, more visual, prop-oriented toys to encourage children to speak about their emotions. There are loads of nice books published that you can, as a parent, you can also download for free with images of different animals being frustrated, angry, furious, and then calmer, and finally happy with their own behavior. A child learns how to identify their own behavior through the examples of those visual representations. What is also very popular is the emotional thermometer. Every ADHD child should take the emotional thermometer to school. And that emotional thermometer is either, it can be a drawing, or it can be even a homemade toy, which shows the red, high temperature, when the child feels that something is happening and they don't understand what, and they can take the thermometer and go to the teacher and just show, I'm in the red zone. I don't know what's happening, but the child knows that it's safe to go to the teacher and just show, I am in the red zone. Before I escalate, there is the danger that it can happen. So the thermometer is a very popular and I think helpful tool that every family can develop. And the booklets that I will send the link to. Otherwise, I would emphasize it again, the language, the reflective vocabulary that we can start with children as young as 3-year-olds, because they can, through your own examples as parents, through your own modeling, how you speak about their behavior, you can change the image of a child of being aggressive, lazy, and stupid to being talented, different, and aware of their own emotional states they can try to control.
Yeah, a very useful information. Actually, I used a few of these during pandemic. In 2020, at the outbreak of pandemic, many children left school. We run a school here in Ahmedabad. I will not take the name because that is not appropriate. But many children left school, and in many parts of the world, actually. Then I founded this I for Inclusion with the help of my friends in the UK, in the US, and Nigeria as well, because African countries were also in a very bad shape. And out of this collaboration, we started getting all these materials, a lot of materials, I would say. And we used to make free resources, and we used to give it to the parents whosoever approached us, and also started webinars, training sessions. All of these were free of cost. And for the last 2 years, we have been doing this. And now, since things are a bit regularized, so we are conducting these live shows so that some way or the other we can reach out to the parents. And after the pandemic, when the children have started coming back to school, uh, what we can see is they are full of aggressions, because for the last 2 years they were at home, and now they're coming back. Everything is new and they're a bit confused. And many things has happened, like many things have happened in their lives. Many children have lost their grandparents. Some of them have lost their parents or very close relatives during the pandemic. And all these things are now showing, coming out in their behaviors. So we really have a hard time in schools these days dealing with our children. Like they are full of aggression these days. There are a few comments as well. So nice. It was indeed a very good session, and it's almost time. There is one more comment, a beautiful expression. Thank you very much, Siddharth and Marta, for taking out some time from your busy schedule and coming here to Let's Talk Inclusion. And yes, I also thought of a few more questions to ask you, but it's nearly an hour. So I think it is time we conclude our session here. But before we conclude, some concluding comments or maybe suggestions for parents and teachers and whosoever, clinicians, whosoever is watching us today. Siddharth, I will first come to you.
Yeah, so I think together we would all love to, bring a change in our society and the attitudes that we have towards neuro disability and disorders. So it just starts with a diagnosis, but there's a lot of work to be done afterwards to have uh, children and adults bloom and reach their true potential. So I think a lot more has to be done, and hopefully programs like this will help raise awareness. And I think people like Marta and a lot of other people who are doing work in this direction, we just need to keep working on it.
Thank you very much. Thank you, Dr. Shah and Marta. Can we have your email ID?
Thank you very much, Manobina, for inviting us. It was a great pleasure to be here, and I hope that more people will learn from your I for Inclusion sessions, which are very impactful, and I think can really sometimes change lives when you think about it. More awareness is needed, more education is needed, and you are doing it.
It's a humble effort from our part, and thank you very much to the experts like you who agreed to come here and address our viewers. And without your support, we couldn't have done anything. Thank you very much for that. And there are people who are asking for your email ID, Siddharth and Marta. What I suggest you can, in case you would like to give it to them, I don't mind, or else they can send us and we can forward it to you, whatever you feel like. Marta, Siddharth?
Yeah, I just shared it. I don't mind. My email is in the public domain related to my consultancy that is called Light Off, so you can find me very easily.
All right, or else I can write it on the comment section so that they can have it. Okay, and this video will have more viewership later on because this is going to be shared, and from all over the world, people will be enriched by whatever you say today, your talk, and then maybe they would like to contact you. So in that case, I will share your email ID. And for you, Siddharth, do you want me to forward the emails to you?
Yep, not a problem.
I will do that. Thank you very much. Thanks a lot for coming here. There are more comments. Oh, okay. I think I have showed this. Yeah, I have shown this previously. Great. Thank you very much. Thanks a lot once again. And it's time to conclude our program. But before we do that, viewers, thank you very much to all of you for your most enthusiastic participation to our session today. And as I say, this episode will be available on Facebook and LinkedIn for our followers to watch later as well. In case you have any query, kindly write that on the comment section. We'll get back to you. And we will come back soon with the 46th episode of Let's Talk Inclusion. Please keep an eye on our Facebook and LinkedIn page for the announcement. Till then, take care and goodbye.
Bye-bye.
Bye, Siddharth. Bye, Marta.
Bye, Sid. Bye, Manobina.